Hello, I'm Donald Macaulay, and welcome to medicsvoices.com, where we talk to the key opinion leaders around the world. Today we're in Canada, and we're talking to Roger Strasser. But Roger, you've had a remarkable academic trajectory. First of all, tell us a little about your academic journey.
I grew up in Melbourne and I studied medicine at Monash University. Even then, I was interested in medical education and the academic side of things. The original GP training program for Australia, which was called the Family Medicine Program, started while I was a student, and I connected with the leaders of that program as a medical student. And so that interest, I guess, in the academic side of things was early on in my medical professional journey. And I actually chose to be a rural GP and undertake rural GP training, which I did in Australia, but in the state of Victoria, specifically in the program there. In those days, it was pretty common for Australian junior doctors to go to the UK for further training to prepare particularly for rural practice. And so that's what I decided to do. But I was persuaded, because of my involvement and interest in education, to delay going to the UK, and spent almost a year with the family medicine program as co-state director. So even as I was still really a trainee, I guess, involved. And while I was there, we hosted visitors from Canada, and specifically a guy called Michael Brennan. And I met Michael and got to know him and learned about the master's program that they offer at what was then called the University of Western Ontario in London, Ontario. At the end of the year, I went to the UK and pursued further training in surgery and anesthesia, which was my plan. My first day in the UK, met Sarah, who subsequently became my wife, and in many ways a co-conspirator in this story, because she also she started her GP training in the UK and then completed that when we went over to Canada. So I was really taken by what I heard from Michael Brennan about the training available. And so I thought, well, I wasn't thinking of this kind of further training yet, but since I'm away from Australia, why don't I just, apply and see if I can get in? And I did, and I was accepted. So after 2 years in the UK, went to Canada and had 2 years based in London, Ontario. The chair of the department was Ian McWhinney, and he's one of the really founding fathers of academic family medicine, originally, of course, from the UK, and so it was a very exciting department to be part of. And Sarah completed her family medicine training with Ian McWhinney as one of her supervisors. We then together returned to Australia. My interest in academics obviously was there, having undertaken the training, and Neil Carson fairly quickly connected. And essentially, Neil kind of encouraged me to develop a master's program for Monash called the Master of Family Medicine, drawing on the experience that I had from Canada. And so I worked in Neil's department and with Leon Pitterman in particular to develop this program. Leon and I basically were trained in distance education to turn the Master of Family Medicine into a distance education program. And more or less overnight, we went from struggling to have half a dozen GP graduate students turning up to the department each week to having over 100 students. About half of them were in rural practice, and of course spread around Australia, subsequently around the world. So the Monash Master of Family Medicine program really took off because it was by distance education accessible to GPs. And for me, there was another development at that time. It started off with the name Centre for Rural Health, and subsequently became the Monash University School of Rural Health. And in 1992, I was appointed as the first professor of rural health in Australia. And that was something that was pretty much unknown at that time in Australia, and probably anywhere in the world, really. During this time, there were developments, of course, not only in Australia, but also in Canada. In Canada, there are lots of parallels and similarities, and of course some big differences between Australia and Canada. But they they were experiencing challenges with just having enough doctors really in Canada, even in the big cities. And so in the province of Ontario, the big city and the capital city is Toronto. And even in Toronto, they were noticing shortages of doctors. And that led in 1999 to an academic rheumatologist called Rob McKendry to be appointed as the term was fact finder on behalf of the Ontario government to look into these issues and make recommendations around medical workforce for the province. And there was one line in this full report that mentioned the idea of a northern rural medical school for the province.
Can I stop you just for a moment? Because
yeah,
many of the people watching, listening, and reading will read about Ontario and the way you describe Ontario, but they will have no concept of the geography.
Yeah.
Just explain a little bit about the geography of Northern Ontario.
So Northern Ontario is north of the Great Lakes and south of Hudson Bay and James Bay. So getting into the sort of almost into the Arctic region. So the eastern border of Ontario is Quebec, the province of Quebec, and the western border of Ontario is the province of Manitoba, and takes about 2 days to drive from the east to the west, or vice versa. So it's geographically vast. And Thunder Bay has a population of about 120,000, Sudbury about 160,000, and they're 1,200 kilometers or 700 miles apart. It's never a straightforward drive because, of course, in winter, the snow and ice, and that affects travel on the roads. And when it's not winter, it's construction season because they're fixing up the roads that have been damaged by the winter weather. So, it takes a minimum of 12 hours to drive between Thunder Bay and Sudbury. So that's Northern Ontario. Geographically vast and never really had enough doctors or other health professionals providing health care. And just to put that into perspective, it's about 9% of the population of Ontario and 90% of the geographic area of Ontario. So in 2001, the Ontario government announced that Northern Ontario, what became Northern Ontario School of Medicine, NOSM, was going ahead. And that's was actually in 2002 that I was recruited to be the founding dean of NOSM. So by that stage, Sarah and I had 5 children, and Sarah and the 5 children, I relocated to Northern Ontario and actually made a home in Sudbury.
So running a medical school in Northern Ontario was quite a challenge, and clearly there was a need for doctors. So where did your students come from, and did they stay?
Because there had been really people across Northern Ontario and had advocated to have a Northern Ontario School of Medicine, there was a widespread excitement, anticipation, desire for this medical school to happen, to be a success, and to deliver for them, for the people in the communities of Northern Ontario, which was fertile ground for really developing NOSM, very much driven by social accountability. The government decision was that NOSM would serve as the Faculty of Medicine of the universities in Thunder Bay and Sudbury, so Laurentian University in Sudbury and Lakehead University in Thunder Bay. And the mechanism to have a single medical school for Northern Ontario, but serving the Faculty of Medicine for 2 universities, was to create NOSM as a separate entity, a not-for-profit corporation with the 2 universities as the members, like the shareholders. And written into the actual founding documents was what we came to describe as a social accountability mandate. So the commitment to improve the health of the people and communities of Northern Ontario. So that really drove everything we did, including the selection admissions process. So we chose to aim to reflect the population distribution of Northern Ontario in each class. And generally we're successful. 92% of the medical students at NOSM have grown up in Northern Ontario. The other 8% come from remote and rural parts of the rest of Canada. And within that group, 40% from rural and remote backgrounds. generally 20+% Francophone, which is about right for the population. Initially, in the first decade, it was 7% Indigenous. So we tweaked the selection process and brought it up to the 12%, which is the way it is now. So yeah, we're basically looking for students who are likely to thrive in the Northern Ontario setting, and those who've grown up in Northern Ontario are much more likely to thrive and be responsive to the curriculum model that we developed for NOSM.
Now, I read about your curriculum and I read about the students' immersion with the Indigenous communities. How did that work?
To give the background to that, I need to say that we started the curriculum development for NOSM with a curriculum workshop that was in January of 2003, and we invited everybody who had an interest to come to this workshop. We thought if we got 200 people, we'd be pretty doing well. We had over 500 expressions of interest. Out of the 300, there were about 50 Indigenous people, and most of the 3-day workshop was in groups of 20 or so in discussion. And listening to what I was hearing from the Indigenous people, I realized that if we were really going to understand and deliver what Indigenous people were looking for from their medical school, we need to have a separate workshop that was just Indigenous people, which we did about a few months later. It was in June of 2003 at a First Nation in the Northwest, just near Kenora. And we had 3 days in small circles and large circles, and listened to the experience of Indigenous people as medical students and as doctors. And that was called Follow Your Dreams, that first workshop gathering of Indigenous peoples. We had over 100 Indigenous people from right across Northern Ontario. And the recommendations from Follow Your Dreams included some really key elements that then helped shape the Indigenous dimensions of the school. The first of which was that all the students should have an early immersive cultural experience in Indigenous communities. And so that's what happens with the NOSM curriculum. As far as I know, it's still the only medical school in the world where all of the students have 4 weeks of living and learning in Indigenous communities. And I described the geography of Northern Ontario earlier. These communities include very remote communities that you can only access by airplane most of the time. In the winter, they cut ice roads to bring in heavy supplies and equipment, but they're very remote communities. And the students, generally 2 students for each community, and they spend 4 weeks in the community, and they're there to learn from the community about the history, the tradition, the social and the health issues of the community.
Now, having set up this medical school and a really innovative curriculum, I guess people ask, how do you measure the success of the innovation?
Yeah, so it was very important for us really from the beginning to actually study what we were doing. Tracking research was started from the beginning of NOSM, and impact research, so looking at the impact of NOSM on the communities of Northern Ontario, looking at in terms of success or otherwise with recruitment and retention of doctors, and also looking at economic impact. And then over time, and we've been able to study what happens to NOSM graduates in terms of their choice of specialty and location of practice. So 10 years after first graduation in 2019, we looked back and we found that 74% of the NOSM graduates were in family practice, and another 14% in other general specialties, so general medicine, general surgery, pediatrics, etc., which is 91% generalists, and 9% in subspecialties like dermatology, radiation oncology, neurology. That 9%, of course, was important to us in Northern Ontario because those subspecialists are needed in Northern Ontario, and they had to go elsewhere for their postgraduate training, but many of them have come back. And we found that of those who went into family practice and did both their undergraduate and their postgraduate in Northern Ontario, 92% are practicing in Northern Ontario. We also did research looking at particular communities and found that the communities, small communities that had embraced the NOSM model and got involved with having students and residents in their community, they really turned around the medical workforce situation. So the study that we did before NOSM, there were 30 full-time equivalent vacancies between these 8 communities. At the time of the study, there was only one vacancy amongst those 8 communities. The students, yes, they have their classroom learning, which is in small groups, what we call patient-centered case-based learning. And the cases are complex real-life scenarios set in real communities in Northern Ontario. So even in the classroom, the students are learning in teams to be team players, but also learning as if they're going to be serving these communities in Northern Ontario. So learning in context. And then you have the 4 weeks in the Indigenous community in first year, and then in second year, twice they go to small communities for 4 weeks in immersive community experience, which is a clinical attachment to the health team in those communities, usually population less than 5,000. And then in the third year, which is the principal clinical year, the year where the students make the transition from being classroom learners to clinicians, they leave Thunder Bay and Sudbury and they go to one of 15 communities, and they live in that community for the whole academic year, which is 8 months, and they're based in general practice and they see patients. So you could say the curriculum walks through the door. You know, the first patient might be pregnant, that's obstetrics. The next patient might be a child, that's pediatrics. The next patient might have a surgical problem. The learning objectives or learning outcomes set for that year in the 6 core clinical disciplines of medicine are just the same as in the other medical schools that do block rotations, clerkship blocks as they call them. But the learning environment is very different. The students are learning their core clinical medicine from the community family practice perspective. And what we've found by studying this is we've come to understand that it's the intense interaction with patients that really motivates the students to study hard and do the best they can for their patients. And so I think that helps to explain the outcomes in terms of career direction that I've described. So that's the curriculum model, but it costs more per student per year than the standard model. And so it was important for us to show that it was a worthwhile investment on behalf of the Ontario government. And so what we were able to show was the economic impact of NOSM, and that for every $1 of taxpayer money spent, there's more than $2 of new economic activity that wouldn't happen without the medical school, and that economic benefit flows through to the small communities, not just Thunder Bay and Sudbury, the big centres, but actually the small communities, more or less proportional to the number of learners, medical students and residents that they have.
I'm incredibly impressed by your terrific pioneering achievements. The question now is, what are you going to do next?
Actually, so Sarah, as I described, sort of very much was on the same journey and got involved in the academic side of things as I did. She came over and really was, you might say, a partner in crime, really, in establishing NOSM in the early years. After about 5 years, she was drawn back to Australia, and she helped Flinders University establish the Northern Territory Medical Program in Darwin, in the far north of Australia, very much modelled on the NOSM experience. So while she was there and I was still in Northern Ontario, I would come over and talk about what the tropical north could learn from the frozen north. And later on was with the University of Queensland and helped start regional medical programs in the southern part of rural Queensland. So after I finished with NOSM, we decided we'd like to actually work together and live in the same place. And that opportunity came up in New Zealand. We spent a couple of years with the University of Waikato, where Sarah was the dean of the School of Health, and we were advocating for a medical school. Unfortunately, the New Zealand government wasn't persuaded by this advocacy. And the current new opportunity for us is here in Vancouver, where Sarah and I are working together. I'm the interim dean and she's the interim vice dean, helping the Simon Fraser University prepare to establish the Simon Fraser University Medical School.
Well, I can only say that the Simon Fraser University are incredibly lucky to have you. It's been fascinating talking to you. Thank you very much for sharing your incredible career, and may I wish you success in this new venture. Thank you very much indeed, Roger.